This is Michael Altos recording Basic Principles of Clinical Pharmacology based on Barish Chapter 7. This is Part 2. We've talked about absorption and distribution of drugs, and it's time to talk about transfer and transport. We know the drug is on its way to the brain, and what actually has to happen? Well, there's a blood-brain barrier, which is made up of a lipid bilayer, and most of our cell membranes are made up of this lipid bilayer. So lipophilic drugs are usually able to cross this bilayer pretty easily through some sort of passive transport. Hydrophilic drugs have a harder time crossing this and may need to go through some sort of a channel via facilitated diffusion or even active transport, especially if they're moving against a concentration gradient. Before we go any further, we need to take a minute and do a quick review of acid-base chemistry. Drugs are typically either an acid or a base. For our purposes, we'll define an acid as any drug that can be dissociated into a proton and a negatively charged species. A base is any drug that can accept a proton to become a positively charged species. Well, we know that charged species don't cross membranes very well. And then we come to the pKa. And very simply, the pKa is the pH where ionization occurs. It's the 50-50 point. It's the point where half of the drug is ionized and half of it is not. Now, when the pH of the environment is more acidic than the pKa, I like to think that there's an excess of hydrogen ions and it pushes the equation to the right. When the current pH is more basic than the pKa, then I think of it as having a lack of hydrogen ions and the equation is pushed to the left. Let's see some examples of this. If we take a drug like etomidate, now etomidate is a base, which means that it can accept a proton to become positively charged. Etomidate has a pKa of 4.2. Now if I inject it into the blood, which has a pKa of 7.4, we can say that the blood, the environment, is less acidic than the pKa of etomidate. And I think of that as being a lack of hydrogen ions, which will push this equation to the left. And so the equation being shifted to the left makes this non-ionized species the predominant species. And that's great because that's the species that will cross the blood-brain barrier and put our patients to sleep quickly. On the other hand, we have propofol, which is an acid. Propofol dissociates into a proton and a negatively charged species. The pKa of propofol is 11. So even though it's in the same blood, now the blood is relatively acidic compared to the pKa of propofol. And I think of that as being an excess of protons, which pushes this equation to the right. And so the predominant species is this HA, which is again non-ionized. And propofol is non-ionized in the blood, which again allows it to have a very quick onset of action in the central nervous system. Let's take a look at this simulation over here. Here we're seeing a membrane dividing. On one hand we have our ionized drugs, and the other hand our non-ionized drugs. The charged drugs can't cross the membrane. But if we add some acid to one side of this, so here comes some protons, and the excess protons mix with the negatively charged drug to make a neutral species that can cross the membrane. Let's stop here for a moment. If you have any questions, you can make a note of them and bring those questions to class, or contact me and I can explain them to you in more detail. Now finally, the drug has had its effect, and it's time for biotransformation, or metabolism. Metabolism is really the process of making our drugs hydrophilic so they can be excreted, and this usually happens in the liver. There are phase 1 reactions, which are some sort of hydroxylation. This is usually done via the cytochrome P450 family of enzymes. Most commonly the 3A3, 3A4, 3A5 subfamilies. That's what we see for midazolam. In general, drugs can be biotransformed in many different ways by the cytochrome family. They can be oxidized or reduced, hydrolyzed, and a lot of drug interactions happen here if two drugs are competing for the same enzyme or changing the levels or activity of an enzyme. We also have phase 2 reactions, which is conjugation. For midazolam, this would be glucuronidation of the phase 1 metabolite, but we can conjugate it with other polar substances besides glucuronate, like acetate or glutathione. Again, the purpose is to make our drug more hydrophilic so it can be excreted in the kidneys. Just a reminder that neonates have a significantly diminished phase 1 and phase 2 activity. Now, when we talk about hepatic metabolism, there are a few terms we need to define. The hepatic extraction ratio is talking about how much drug is removed by the liver for a given drug. And this is based on the drug's intrinsic hepatic activity, which our book calls Cl with a lowercase I. Hepatic clearance then is going to be based on the extraction ratio, which is how much drug can the liver take out of blood that's being sent to it, and also the blood flow. How much blood are we sending to the liver? This is illustrated in these two complicated graphs over here. The first graph is looking at hepatic clearance as a function of liver blood flow. Let's start with a drug with a very high intrinsic hepatic activity. This is a drug that is readily metabolized by the liver. And as we send more and more blood to the liver, hepatic clearance continues to go up and up and up. The liver is ready to metabolize this drug under almost every circumstance. But if we imagine a different drug, one that has much less intrinsic hepatic activity, this is a drug that is not as easily metabolized by the liver. So at low liver blood flows, well, the liver can keep up. But as we send more and more blood to the liver maxes out. It can't clear any more drug per minute. And that's because the drug does not have very much intrinsic hepatic activity. Drugs with high intrinsic clearance, like etomidate or propofol, basically their hepatic clearance is directly related to their hepatic blood flow. And these are drugs that have a high extraction ratio. And only when cardiac output decreases will we start to see diminished hepatic elimination. Let's look at this second graph for just a moment. Again, here's a drug like propofol with a high intrinsic hepatic activity. So when liver blood flow is very low, of course, we're able to extract almost all the drug from the blood. But even if we continue to increase more and more blood flow to the liver still extracts almost all the drug from the blood. Why? Because it has such a high intrinsic hepatic clearance. But a drug that has a lower intrinsic hepatic clearance, well, at low liver blood flows, the liver can keep up. But as blood flow gets higher and higher, the liver is able to get a smaller and smaller fraction of drug out of the blood as it passes through the liver. This would be like a low intrinsic clearance drug, like thiopental, where your hepatic clearance is really pretty much limited by your intrinsic clearance. You don't have to memorize this, but there are lists of drugs that have low, medium, and high hepatic extraction ratios. And this is interesting because compared with the kidneys, where in the kidneys autoregulation maintains a constant renal blood flow always, whereas here different drugs may have very different metabolic effects as a function of liver blood flow. Finally, we should talk about elimination. Elimination almost always happens via the kidneys. Now, it's important to know that renal drug clearance is comprised of more than just your renal blood flow. Your glomerular filtration rate is about 20% of your renal blood flow. And so just passively filtering drugs through the glomerulus is not sufficient to clear all of the drug that we need to clear. And especially if drugs are protein bound, which means they won't readily filter into the kidneys. But fortunately, we have a second mechanism, which is renal tubular active transporters. So in addition to filtration at the glomerulus, we have transporters that will send additional drug into the kidneys. And by the time we're done with that, the amount of drug being filtered into the kidneys is pretty much close to renal blood flow. We know that decreased renal function can require us to change our dosing of certain drugs, especially in drugs that have active metabolites. And it's good for us to know which drugs have significant renal excretion, and I've listed those drugs here. We're going to stop here with this recording. If you have any questions, feel free to contact me or bring those questions to class, and we'll pick up with the next recording.